Good afternoon, and thank you for joining me for another Leadership Rounds. I'm Dr. Rod Hochman, the President and CEO of Providence and the Board Chair for the American Hospital Association. May was Mental Health Awareness Month, but every month is the right time to continue the discussion of an issue that I think has never been more relevant: behavioral health. This past year, the pandemic has taken its toll on our country, physically, economically, but more importantly, emotionally, and further worsening what was already a crisis that we were talking about before the pandemic. At Providence, we've taken a number of steps to support our caregivers, including 24/7 access to counseling at no cost and 2 new programs: No One Cares Alone for our leaders, and My Mental Health Matters for all of our 120,000 caregivers. I know other systems and hospitals have ramped up their services as well. That said, this is the critical time to renew our focus on mental health and well-being. Its vitality, important for our workforce, but just as important for our patients. It's a pleasure today, we're so lucky today to have a guest who's an expert in this field. Dr. Robert Trestman is a professor and chair of psychiatry and behavioral medicine at the Carilion Clinic and the Virginia Tech Carilion School of Medicine. Carilion, as I know well, is located in Roanoke, Virginia, with its incredibly strong CEO, Nancy Agee. I just added that in. Dr. Trestman received his PhD in psychology and MD from the University of Tennessee, trained in psychiatry and neurobiology at the Mount Sinai School of Medicine in New York City. He's authored over 180 peer-reviewed articles and other publications, and is the senior editor of the first textbook in the field of correctional psychiatry. Dr. Trestman is also the co-developer of Start Now, a skills-based psychotherapy used in multiple countries. Dr. Trestman is currently serving as the chair of the American Hospital Association's Behavioral Health Council and serves on many other professional boards and committees, including the American Psychiatry Association. Dr. Trestman, it's an absolute pleasure to be with you at such a critical time.
Thank you so much for the opportunity.
Great, and as I alluded to before, research and statistics right now are just so sobering. 3 or 4 in 10 healthcare professionals are burnt out to a point of quitting. What do you see as working for the best support for our caregivers?
Well, there are many things, and I think you've already alluded to several of them. We've found nationally, from the experience I've gained through the AHA and other organizations, is that many of us have relied on a range of services. So we found that no one thing is a golden or magic bullet. But ultimately, having access to care, having reduced barriers to that care, having different forms that are available at different times and locations, and having a different range of support that frequently isn't normally considered direct supportive therapy. Having access at times to new financial supports for times when people have gone through periods of furlough. Is something we haven't had to deal with before for our staff. Helping them to come up with strategies to care for their children who they would have expected to be in school, but now they have to find strategies to care for them. So we've had to come up with ways to support people that we hadn't really had to think about before. So it's called upon health systems to be far more creative to address the needs of the people who we rely on to deliver the care to our patients and our communities.
Yeah, I get the sense, you said it really well, that the surrounding environment is so stressful. And I kind of look at the big stressors that are out there, the financial environment. We're seeing women have to leave the workforce because they don't have child support, the financial stresses, and then just, the political environment in which we're in creates like and I just say it, I admit it to all of my people. I have a higher level of anxiety every morning that I come in. And I think that has really, in a lot of ways, just even made it even more of an issue than when we started the pandemic. Anything else, you've seen some of the programs. If you had to say, what do you think the intervention is that is the most important? If we were talking to our audience now, we're talking to all the health systems, and someone said, if we're going to do a lot of things, what should be the one thing we start with?
The one thing is to help health professionals, whether we are nurses, psychologists, social workers, or physicians, nurse practitioners, physician assistants, to realize we are human beings. We are not superhuman. We all have our limits, and it honestly is not just okay, but appropriate to receive support and help. Overcoming the stigma of asking for and receiving help is the single biggest challenge I think we all face.
So what do you think, and I'm going to go off script here a little bit with the questions, but this whole issue, I look at stigma, a number of years ago, we had the issue just with having cancer was stigmatized. Then we went through the whole HIV crisis, and finally we understood that. But I have the sense that we still have a lot of stigmatization as it results with mental health, that, it's going to jeopardize your job if you're a political figure, et cetera, et cetera. Any secrets there to how we destigmatize the issues that we're dealing with in behavioral health?
I think we're going down the same journey that we went through for cancer and for HIV and other conditions. We're learning the underlying neurobiology, pathophysiology of the underlying conditions. We're making them less magically fearful. And so as we learn that these are brain disorders, they're treatable disorders, and we can address them, then we can work to overcome the stigma. I trained during the HIV epidemic. I remember the fear that people had about touching a patient, about doing surgeries on patients. And so we worked to understand what were the genuine risks, what the real fears, and we worked to develop protocols to overcome them. And we worked really hard not to ostracize the patients who needed our care. If we are the people who need to be strong to care for others, we can make use of that same information to realize, look, if I need to take medication for my elevated cholesterol or for my heart condition, no one is going to question my ability as long as I can demonstrate my skills. Same thing should apply with any psychiatric condition.
Absolutely. And I'm going to ask one more too, that I my background's in immunology and rheumatology. Looking at the effects of folks that have had COVID, so both our caregivers, but also our patients, there seemed to be a fair amount of neurologic and neuropsychiatric effects, particularly on people that have prolonged effects from COVID. Any thoughts on that?
Oh yeah, I think the evidence is growing that this is a vascular inflammatory agent that causes a cascade of problems anywhere there are blood vessels, which is everywhere. And so a lot of the microvasculature in the brain, as well as in the heart and the lungs, is profoundly affected. And we are beginning to see that, not just in olfaction and gustatory or taste perception, but also in concentration and mood regulation, memory formation and retention. There are many issues in long COVID, and we're beginning to understand this, and hopefully we will have treatments for it. But it's likely going to arise from our understanding of its inflammatory nature.
A lot of analogies to Lyme disease, which I knew a lot about as we understood it, and we understood that more than just an autoimmune or a rheumatologic disorder. There are a whole bunch of neuropsychiatric effects and neurologic effects that come forward. Tell me a little bit about your own organization and what you guys have done specifically to adapt, particularly for your health professionals, and what services have you initiated there to support your staff?
I think what we've done mirrors what many advancing healthcare systems have done. We have expanded access to our EAP for our own staff and dependents. making it available all hours of the day. We have expanded our chaplaincy so that they are now, as they do their rounds, are not just focusing on family members and patients, but also checking in with staff. And literally, specifically, they're charged with asking staff, how you doing? Because the boundaries and the thresholds are lower, interestingly, because they're well-known faces, they're trusted. We have lots of virtual support, online peer support, so physicians to physicians, nurses to nurses that are scheduled and people can drop in. They know what the Zoom location is and can make it there. For the high intensity areas, we have had in-person support through most of the pandemic, wearing PPE, but in person, people being able to take 10 or 15-minute breaks. We put in more and more Watson rooms where people are able on shift to take, during their breaks, a chance to decompress. We have expanded access to virtual wellness programs so that people, even at home, can participate in competitive, have you gotten your steps in today? Let's join teams. We've worked to destigmatize access to care. We have made it easy to get access to care. We have tried to make it fun. We have had lots of different supportive initiatives where even virtually we bring people together for parties. So we send the party goods to people or their floors or their homes, and then have scheduled times for them to get together virtually. So like most organizations, I think we've done a lot of the same kinds of things. I hope what we've done successfully is weave them together so that people can pretty seamlessly move from one level to another in support.
How do we measure? We're doing all these things, and the thing that for both of us, how do we do all these things? How do we measure its effectiveness? What should we be looking for as we're evaluating our staff and everything else to say the interventions are working or they're not working?
I think, sadly, we can begin by using very crude measures of absenteeism and turnover rate. And I think those are ultimately critical outcome measures, because that's in large part what we're trying to target. We can also look at more local, focal processes with occasional administration of burnout scales or engagement activities, as well as encouraging staff meetings within their units or working groups to be able to get feedback, as well as having the opportunity for anonymous feedback. One of the things we're using as well is our Safe Watch program, where everyone has been encouraged to report near misses or mistakes, and we're tallying those, looking for patterns and trends to see whether or not they may be related to dysfunctional activity, to exhaustion, to burnout, to withdrawal.
Got it. And the other thing is that we play an important role, our hospitals and healthcare systems, in providing behavioral health care, whether in our own facilities or connecting people with resources. Are there new ways we should be able to support this? And I'm going to speak for probably everyone that's watching us. If you and I made rounds at the emergency rooms across this country, I think that every emergency room director would say, we've got a crisis in behavioral health. I'm boarding, patients in my emergency department, and they have nowhere to go.
You're spot on, and that's true, and it's only going to get worse. The pandemic we've all just lived through and are living through with the new Delta and Epsilon, and very likely other variants are going to.
I think we're going to run through the whole Greek alphabet, one after another, right?
Yes, I'm afraid we will. What we've done and what many other healthcare systems are doing is thinking to the future of healthcare and recognizing that unless we want to be isolated as trauma centers and quaternary care only, we need to partner with our communities. We're working with our schools, with our child protective services groups, our adult protective services. We're trying to create trauma-informed communities. We're trying to link up services with those who are partnered with us, but with whom we have no fiduciary oversight or control, but we all want to work together to build a safer, better, healthier community.
Because the thing that I think we've been struggling for, I think it's been an issue that you and I would probably, if we were talking 10 years ago, is this separation between physical health services and behavioral health services. And are we going to finally get those integrated? Because that I think has been probably one of the biggest, barriers. And that was something that, came up during the 90s. And you and I both probably lived through that, when there was this wall that was put between your mental health coverage and your other healthcare coverage. And do you think we're going to be able to finally break through those barriers?
Yes, and I think we have to. When we look at people with serious and persistent mental illness, on average, they die 10 years earlier from other general medical conditions. Those with general medical conditions, chronic pain, really refractory diabetes, will in 40 to 50% of the cases have a co-occurring mental illness, depression or anxiety disorders. Beyond that, so many patients with lung disorders, cardiovascular disorders, endocrinologic disorders like diabetes need support in participating effectively in care. And that's our expertise. Yeah. So the more we work collaboratively to provide care, to keep people healthier, is going to be the genuine measure of our success. And I think financially, we're being driven there. We can't sustain a 19+% GDP expenditure for healthcare.
Yeah.
Not with the outcomes we're getting.
Absolutely. The other thing that I've seen that gives me some hope is that we're finally integrating screening at the primary care level. I was just with a close colleague of mine, that would be my wife, who had to go to the hospital yesterday. But as part of every part of the screening, they said, we're just going to ask these questions, and we're going to do that. And you can see it's really been built in to what the intake is, and asking the questions about safety at home, but also safety for yourself. Do you see that? Is that, isolated, or is that something that we're doing a better job with?
We're doing a much better job of screening for that around the nation. The challenge, unfortunately, is once we screen for it, then what? Right. We need to have the capacity to rapidly refer people into appropriate evidence-based treatment for the disorders we recognize.
Yeah, absolutely. And particularly, I think, for our young people, it's almost an epidemic, particularly our young, the teens for sure, but even, pediatric patients in terms of that kind of screening as well, right? That's not a group we should forget about.
Sadly, no. The incidence of youth suicide attempts has gone up during the pandemic. The frequency of addictive behaviors has increased, as well as general depression, anxiety, and traumatic stress disorders in teenagers and children. Our emergency rooms and our child and adolescent inpatient programs nationally are now saturated.
Absolutely. I've got one more question. I could probably keep you for an hour here. And, I think, if we look at what the big rocks are for the next 5 to 10 years, clearly mental and behavioral health is there. There's been longstanding issues around inadequate reimbursement for behavioral health services. And I know it's affected your field incredibly, as well as, provider shortages. And, how do we look at the workforce in behavioral health? How do we look at some of the reimbursement issues? And what's your assessment of the effect that the reimbursement shortages, reimbursement inadequacies have on behavioral health workers?
It's profound, simply. But, as any executive in a healthcare system knows, these days, building out a full thickness system of psychiatric care is an investment. It is not something where you break even. It's not something where a health system makes money on. And so how is it that we change that dynamic so that it's not an investment that the health system has to make. We need to look at it. CMS has recently, for Medicare, shifted their relative value unit compensation for multiple cognitive specialties. That's a very good start, but that has a profoundly negative impact on most healthcare systems, who then are looking at a zero-sum game or worse because of all the proceduralists. And that's critical for us as healthcare systems, because there's nowhere else for people to go when they're critically ill. So we need to look as a nation at appropriately funding this. And in my opinion, that means some type of capitated or global compensation that is predictable and that's affordable, and that is something that we can support our healthcare systems to participate in, that doesn't put them at risk, but allows them to bulk up on the needed psychiatric and behavioral health services that would benefit the patients far more globally and keep them healthier than we're currently able to do.
And we'd be remiss too, the points that you're making, we're talking about all the health inequities that exist in society that we've seen that have really come to light, particularly during COVID. But I would say ditto, underline it, that behavioral health is, there's a gap, tremendous gap there of inequity in terms of the availability of services, particularly for communities of color, Hispanic American communities. And maybe just a last comment on that, and then I'll close.
I can only reinforce that. When you look at the social determinants of health that predispose people to be at risk, every one of them is loaded against those populations of color. When we look at adverse childhood experiences, when we look at the kinds of jobs most people of color have been relegated to and the challenges they face, yes, we have real challenges that we need to take ownership for if we're going to make a difference in our communities. Because frankly, most of us as healthcare systems have enormous clout in shaping the culture of the communities in which we're embedded.
That's a perfect thought to end on. And I just want to thank you for joining me and giving all of us around the country your insights. And these conversations are necessary and important so that today, as professionals, as we work with our patients and colleagues, but also for really setting the strategy for how we work with our communities, our friends and families. I encourage anyone who's listening, who's struggling with anxiety, depression, to really reach out to someone for help. And if you don't have a resource, there are a couple on the screen. We'll add this in, for you to be able to look at and be able to see. And then if you're looking for additional tools, visit aha.org to find some great resources that are out there. Tools focused on stress and coping during COVID, newsletters, toolkits, podcasts, case examples, and resources addressing the opioid epidemic. We see lots of hope in the rising vaccinations and finally getting the pandemic, we hope, behind us. But for our patients and our caregivers, their families will continue to need extra support, access to mental health care services, and our focus must be to remain strong on their behalf. So thanks again, Dr. Trestman, for being with us. And till next month, thank you everyone for joining us today. And I hope you'll be back for our next Leadership Rounds conversation.